Now we have Dr. Shyamal DWIVEDI, who is part of our retinal team at Raghudeep Eye Hospital, and he'll be sharing with us something which is very, very important, something which we encounter in, at least in our part of the world in Gujarat. 6 out of 10 patients are diabetic who come for cataract surgery. So he's going to share with us the pearls of managing cataract and diabetic retinopathy. Yeah. Can we have this podium on the screen, please?
Good morning everyone, and thank you Dr. Shail to give me an opportunity. So these are our financial disclosures, and I'll be discussing how to deal with diabetic macular edema along with the cataract. So as we all know that India is set to be a diabetic capital by 2030, and we all are aware about all the dreaded complications which it can give. And the most dreaded complication on the top of the list is the vision loss. So that is the reason we are very, very aggressive in managing diabetic macular edema. So let us discuss how cataract and diabetic macular edema can be managed. So there are two ways to do it. The first is the targeted macular treatment, that is the drying out the macula first by giving appropriate intravitreal injections or lasers, and once it is dry for some amount of time, I mean maybe 2-3 months or so, then we can proceed with the cataract surgery. And the other way is treating the cataract and the diabetic macular edema together with appropriate intravitreal injections, and which is known as the combined approach, and we are currently interested and our lecture is based on that. So these are some common indications, and we would not go into much theoretical details, and it's already proved that diabetic macular edema worsens in diabetic patients undergoing cataract surgery, and thus managing it efficiently remains our primary goal. So this slide is self-explanatory, but the main thing what I want to focus is the gonioscopy to rule out the neovascularization. You may get away with any injections you give, but if you give a steroid implant in a patients with proliferative diabetic retinopathy, then you can be in trouble. So the main thing to emphasize is to rule out the neovascularization in the angles, and as our friends already told that we don't like to do gonioscopy much, so it is very imperative to join hands with a glaucoma colleague so that we can proceed in a proper way. So again, we are not going into the theory part, and as most of you are aware about the DME management options, out of which intravitreal injections are the most popular and widely used modality of treatment. So let us see some real world scenarios now, and our team was also involved in the trials related to the dexamethasone implant, and it has been concluded that dexamethasone implant is a valid treatment option in patients with diabetic macular edema in treatment naive eyes. So here is our first case showcasing a cataract and a diabetic macular edema secondary to non-proliferative diabetic retinopathy. The patient successfully underwent a phacoemulsification along with the dexamethasone implant, and even at the end of 3 months, the patient continued to maintain a decent visual acuity and almost regressed diabetic macular edema even post many months. So let's go with the case 2, and this gentleman is a one-eyed patient. He has an inoperable TRD in the right eye with no PL, and this is the left eye is the only seeing eye, and he has a diabetic macular edema with a significant cataract. So this is a surgical video of the same patient undergoing a phacoemulsification and IOL implantation. So once the IOL implantation is done, dexamethasone implant is injected by a 2-planar entry, usually 3.5 mm from the limbus as seen in the picture. So now I would like to emphasize that my technique to go for the intravitreal injection is to go to the opposite side of the main incision so that you don't open up the port. Yes, we do have viscoelastics in place, but still to be on a safer side, it is better to go on the opposite side of the incision so that you don't press the posterior lip and open the incision, and the AC wouldn't get shallow. So further seeing, so the direction of the needle once in the globe, it is directed towards the center of the globe. It is very, very essential to view the implant in the vitreous cavity as we see right now, confirming that the implant is in place and it is going into the posterior cavity. So this is again the post-operative result, and it is very satisfying to see the excellent visual recovery. So this particular patient underwent a focal and a grid laser, and you can very well see the first picture over here is the pre-focal laser picture, and the next picture is the post-focal laser. We can see the regression of hard exudates in this picture, and the patient is still managing quite well without the need of any further injections. So let us proceed to the third scenario. So this patient is almost looking like a normal patient with a normal fundus appearance in our OPD, and this patient was posted for a cataract surgery. But as we have a very stringent pre-operative measurements, the patient underwent an OCT, and we were surprised to find that the patient is harboring a diabetic macular edema not only in the right eye but also in the left eye. However, the right eye was posted for the cataract surgery, but the OCT has totally a different story to tell. So this was a little older patient, and the patient was subjected to fundus fluorescent angiography to know that what is exactly causing this diabetic macular edema, or maybe it is it a diabetic macular edema, or is it something to do with the uveitis. So the patient was subjected to a fundus fluorescent angiography and to identify the reason of the macular edema, which demonstrated that it is a non-proliferative diabetic retinopathy with a macular edema. So again, the patient was subjected to the cataract surgery with dexamethasone implant, which proved very fruitful to the patient regaining a full visual acuity. So again, this is a case, the next case, and this is obviously looking a very bad looking fundus. And if you see in the right side of your left side of your screen, we are able to see that this is a vitreous hemorrhage and lots of hard exudates and lots of cotton wool spots. So this indicates that this is a patient of a proliferative diabetic retinopathy, and this patient also has a massive diabetic macular edema. It is very essential to note that the patient is having some signs of disorganization of the inner retinal layers, especially in the right eye, which is again suggestive of ischemic macula, while the left eye looks pretty much okay. So this patient was subjected to the OCT angiography, which we have in our clinic nowadays, and we were surprised to see that, not surprised actually, we were expecting this. We can see very beautifully neovascularization on the disc, neovascularization elsewhere just near to the disc, and even this picture not very clear, but still we are able to recognize those fine vessels on the disc. If we go further and if we see, this patient was subjected to an intravitreal anti-VEGF injections, because this is a proliferative diabetic retinopathy case, and we are not supposed to give steroid injection unless the patient has undergone a PRP. So this patient underwent right eye and the left eye injections of an anti-VEGF, but even we could see a very nice resolution of the macular edema, but the OCT angiography shows a large non-capillary perfusion areas, and this patient needs a very, very aggressive pan-retinal photocoagulation even after the cataract surgery, which has to be monitored regularly. And such type of patient, in spite of giving so many injections and PRP, they may still go into a neovascular glaucoma phase. So they have to be monitored with extreme care. So this is a case of one more case, and in this patient we are able to see a diabetic macular edema with a vitromacular traction. So usually the the vitreous is very, very sticky in patients with diabetic patients, and over here it has caused a diabetic macular edema. So in this patient, after the cataract surgery, we were forced to go in for a pars plana vitrectomy. And in this case, we need to see that triamcinolone acts as a very good vehicle to remove the vitreous which was adherent to the retina. So once the vitreous is recognized, we had to use a triamcinolone to do an internal limiting membrane peel, and with which we are 100% sure that the vitromacular traction was totally removed, and this was done with the use of a brilliant blue dye. So once it was completed, we augmented the patient with some more pan-retinal photocoagulation, and that was the end of the case. And we are very happy to see a stellar response with almost resolved diabetic macular edema and restoration of the normal foveal contour. So this is the final case, and this case is very close to my heart, and he is a young photographer and a young diabetic and having all sorts of diabetic complications. So he presented with this picture, both the eye having diabetic macular edema, with left eye having a subhyaloid hemorrhage. So as the OCT showed a massive diabetic macular edema with a taut posterior hyaloid in the right eye and the epiretinal membrane in the left eye. So this patient was subjected to different intravitreal injections in both the eyes, and patient has received multiple injections. However, right eye refused to give any response, while left eye started responding well. So we had to make the patient undergo a vitrectomy in this case, and so after a successful phaco and in the bag IOL implantation, a 25 gauge vitrectomy ports were constructed. So as he is a young diabetic, the vitreous tends to be very adherent, and at one point of time I was feeling that why did I take this case, because I was not able to achieve a PD in spite of trying very hard for a very long time. And at one point of time I thought, let me just abort this case, but I was quite lucky that I kept on trying, and at one point of time I was able to achieve a posterior vitreous detachment very nicely, as right now evident on the screen. So this is the V's ring which I have created, and I don't want to do anything more for this patient. We just need to do a PVD induction, and that is usually the end of the surgery. Of course, because this is a patient with a proliferative diabetic retinopathy, it goes without saying that we need to do a pan-retinal photocoagulation. So after that, that is the end of the surgery, and it was extremely satisfying to see a complete resolution of the macular edema, though there was some foveal thinning, but this patient never required any further treatment, and we have 2 years follow-up of this particular patient, and he is doing extremely fine, and he has also regained all his photography activities and his job. So it is very essential to identify the correct diabetic retinopathy stage and make patient understand about their own conditions, as diabetic retinopathy is a very complex disease. So now the time has come where we need to join hands with a retinal colleague for a better customized approach for the patient. And last but not the least, dexamethasone implant is an excellent choice for patient undergoing cataract surgery with diabetic macular edema in most of the treatment naive eyes after proper evaluation of the retinopathy status. So these are some futures in the diabetic retinopathy which are still going on, still not out. So each and every, most of the things are usually focusing on the underlying edema. So the main thing in the diabetic patients is the edema, and these are all the newer things which are targeting this. So thank you very much for your attention and engagement throughout the presentation.
Thank you so much, Shyamal, for showing that entire basket and variety of cases, right from medical to surgical. But I think the most important take-home message is that we must involve our retinal colleague before planning a cataract surgery in a patient who has even the mildest of diabetic retinopathy, because quite often we may find the foveal contour is okay on OCT, but they may have some new vessels which have developed in the periphery which we may have missed in looking at the cataract. So always get a retinal surgeon opinion done pre-operatively and forewarn these patients that you are likely to have slower vision recovery, you are likely to have macular edema post-operatively even with the best possible cataract surgery and the best intraocular lens. So you'll need to follow up with the retinal surgeon post-operatively also, and if they know beforehand, they will be more ready to accept it post-operatively as well. But thank you so much.
So there is one more observation, that if a patient comes into your OPD and he is having some kind of retinopathy but not a diabetic macular edema, but the presence of ERM is very important. If that patient has just a presence of ERM, the amount of patient developing macular edema or diabetic macular edema is almost 4 to 5 folds. So if you see an ERM with a diabetic retinopathy, it's a warning sign.